Hello, my name is Aissa Suciu, and I am honored to be able to present you the first preliminary results of our research from the CANPRIM project, Beyond Oncology into Primary Care Cancer Distress, follow-up study among outpatients. We do not have financial disclosures for any commercial interest. Cancer can affect anyone, regardless of their socioeconomic or demographic status, and it's a huge burden on patients, their families, and society. Cancer is one of the leading causes of death worldwide. We can estimate that 1 out of 2 persons born after 1960 will have to face one type of cancer during the lifetime. In Romania, during the past year, there were about 99,000 of new cases of cancer, which means about 2% of the total population. We know that cancer diagnosis comes along with high levels of distress for almost half of the people diagnosticated. Half of the people will not know their diagnosis, which increases the odds for depression, anxiety, and low quality of life. And only less than 5% will benefit from professional psychological support. These are some of the main reasons for which the CANPRIM project was initiated. This is the first study at the national level that aims to outline a framework for highlighting the major problems of neoplastic outpatient, the psychosocial burden represented by the experience of oncological disease among them, as well as the psychosocial courses of action for patients with cancer in the context of primary healthcare in Romania. CANPRIM will develop an innovative research platform with primary care providers from 41 counties in Romania. We aim to evaluate the psychosocial aspects of the trajectory of oncological disease in outpatients diagnosed with cancer beyond clinical care using an interdisciplinary approach to psychosocial assessment. Hopefully, our results will enhance scientific knowledge and facilitate understanding of oncological distress, quality of life, patients' concerns about the need for information, and fear of relapse in primary care in Romania, based on current theories and methodological approaches to these research topics. Finally, the CANPRIM project will increase the capacity of our current primary care system to provide psychosocial services to patients with cancer in Romania. Based on the previously presented information, using a mixed method design with 2 complementary directions of study, the main objectives of the present research are to assess and evaluate cancer distress, quality of life, information needs and concerns in 250 outpatients diagnosed with cancer in Romania through quantitative methodology, and to analyze 50 primary care providers' acceptability and feasibility of cancer distress screening and referral process in Romania through qualitative methodology. Next, we are going to focus on the preliminary results of the first objective of our project. Using an exploratory, descriptive, and cross-sectional approach, we aim to screen 250 persons with cancer registered to primary care using a questionnaire, the first part of which is based on the emotional and impact thermometers that monitor the patient's cancer distress in the last week before assessment and how much help and, respectively, how much impact these emotions had on him or her. The next part consists of personal and health data about the patient and contains also instruments for measuring psychological factors such as level and severity of depressive symptoms, patient's quality of life, the fear of recurrence of the disease, the problems that patients may face, the level of information that patients received following consultations, and others. The last part is for diagnosis confirmation, made with the primary care provider and includes items such as does the patient know about his or her disease, stage of the disease, first diagnosis, localization of the tumor, and treatment used so far. So far, we have screened a total of 57 participants, from which 82% were women, all were adults, 70% were married, all were living in Romania, more than a half have had a bachelor's degree. We were able to include so far a wide range of ages between 22 and 84 years old. As we can see in this graphic, the first impact of the diagnosis usually leads to despair for almost 20% of the participants screened so far, and almost 60% of this sample decided to heal at any cost. This may have had an impact about the unhealthy behaviors such as smoking and consuming alcohol, due to the fact that 40% from this sample quit smoking after the diagnosis, 5% still smokes, and 55% declare they never smoke. About 92% declares that in present never consume alcohol, and also upon the healthy behaviors, about 69% engage in physical activity daily and several times a week. About 53% reported that they can't link the disease to a contingency. About 70% consider their financial status compared to the national one as ranging from moderate to high. About the impact that the cancer distress had upon the patient during the last week before assessment, and how much health and respectively how much impact these emotions felt on them. So far, we identified higher levels of stress and anxiety compared to depression and anger. On one side, 53% declared they felt from moderate to severe levels of stress, and about 41% declared from moderate to severe anxiety during the past week. On the other side, about 30% declared that they felt depression during the past week. None of the respondents indicated a level of 9 or 10 on this scale. And about 32% indicated from moderate to severe levels of anger during the past week. About 26% felt a moderate impact level of these emotions upon their life, and about 21% had higher impact levels. 30% felt a moderate to severe need for help, and none indicated a level of 10 on this scale. Thus, we were able to screen people with a wide range of ages from 22 to 84 years old, independently of their socioeconomic status. We were able to see that people indicated higher levels of stress and anxiety compared to depression and anger. One reason could be a misunderstanding of the depression as an emotion and thinking more about it as a disease, and having a mental representation that contradicts the perceived self-image. Though we were able to identify levels of cancer distress such as stress, anxiety, depression, and anger on one side, on the other side, we also know from the preliminary results that the vast majority of primary care providers also acknowledges the distress felt by the outpatients diagnosed with cancer. An interesting fact is that even though declaratively primary care providers said that they were open to undertake psycho-oncology courses in the future, in reality they have shown resistance in collaborating with us and participating to a better understanding of their own needs and perspectives. Not least, receiving cancer diagnosis can impact life decisions to initiate a treatment, to engage in healthy behaviors, or to quit unhealthy ones. To draw up some conclusions, we can affirm that first, we were able to screen adults independently their age, the level of education, familial and financial status, and residence. Second, we were able to identify higher levels of stress and anxiety compared to depression and anger. 47% felt a moderate to severe level of impact of these emotions upon their lives during the past week, and 30% felt a moderate to severe need for help. Third, but not least, there are the psychosocial needs we know that were identified globally. On one hand, we were also able to identify them in this research so far. On the other hand, the primary care providers also acknowledge the existence of the cancer-related distress, but still a minimum % of people with cancer receive professional psychological support. Thank you. Now I will take questions.